My name is Lauren, and I get the great privilege of supporting the team here at Norton Healthcare. I want to welcome you to the first session of COVID and Your Heart, which is designed to be a panel discussion with specialists from Norton Heart Vascular Institute. As you all are aware, the COVID-19 pandemic continues to evolve daily, and concerns about how the virus may affect your heart or if you have heart disease is always top of mind for so many. The information continues to evolve day by day. We've learned so much about this virus. So with that in mind, it's important to note that the information that is presented here today is as good as of today, September 28th, 2021. Also, we want to remind you that everyone's heart is unique, and so too is the care that you may require, and everyone is a little bit different. So it's important that if you hear something here today and you feel like you need follow-up care, that you check in with your primary care provider or speak with your cardiology provider if you feel like you need additional care. If you find yourself in need of a cardiology subspecialist, the team here at Norton Heart Vascular Institute is made up of more than 60 subspecialty providers who would be happy to talk to you about your needs and follow up with you for additional care. You can find more information about all of our specialists and the care that we're able to provide at nortonheartandvascularinstitute.com or by calling the Norton Healthcare Access Center at 502-629-1234. We will put up a slide at the end of this presentation with this information, so feel free to check that out there. Without further ado, let's get started. Our first panelist comes with a great reputation. Up first is Dr. Arpit Agrawal. Dr. Agrawal has been a general cardiologist with Norton Heart Vascular Institute for more than 5 years. He's going to get us started today with our discussion. Dr. Agrawal, I'll send it over to you.
Thank you, Lauren. As I'm sure everyone in this panel knows about, COVID-19 has a significant effect on the heart, and the effect on the heart is something that we've been learning about through the course of the pandemic. Early on, from the onset of the pandemic, we have noted that people who have pre-existing heart disease tend to have more hospitalizations and unfortunately have been dying more frequently. And those conditions include things like high blood pressure, diabetes, smoking, stroke, obesity, heart failure, and pre-existing coronary artery disease. Now, over time, we haven't figured out exactly why people with these conditions have had worse outcomes, but I think there are various potential reasons. We also know that people who have been hospitalized can have exacerbation of these pre-existing conditions, but can also develop new conditions while in the hospital, which include heart attack, heart failure, and arrhythmias. Tara, one of our other panelists, will be discussing a little bit more about arrhythmias, and Ken will be talking a little bit more about the heart failure that's associated with it. I think one thing that many of us have learned about, probably is one of the hot phrases in cardiology, is myocarditis and its association with the virus. We've seen the data evolve a great degree about myocarditis. Myocarditis, which is inflammation of the heart muscle, can have symptoms such as chest pain, shortness of breath, and palpitations or an irregular heartbeat. The incidence, it was very popular in the press that the incidence of this was occurring very frequently initially, but as time has evolved, our estimates of the incidence of myocarditis has also evolved, and we realize it's probably not as common as we once thought. We are still seeing it in a large cohort of patients, regardless of the severity of their COVID, and it's something that often will need further evaluation if you do have that considered. We're seeing effects of COVID both in the acute phase, meaning when people are actively infected with COVID, but I think there's been a lot of information about post-COVID syndrome or long COVID or the long hauler syndrome. And people are often having chest pain, palpitations, and shortness of breath, not just in the first week or so after the infection, but also, but it's persisted for months or even a year out from their infection. The data on that is still evolving. We're still trying to learn more, but hopefully as we learn more, we'll get a little bit more information. I think just don't take the symptoms lightly. If you do have symptoms, consult with your primary care doctor, because it can also unmask underlying heart disease. And don't suspect that all of your symptoms are related to the virus, because this pandemic has lasted a lot longer than we've realized. And there's a lot of disease that people could be attributing to COVID that may be related to just underlying coronary artery disease or heart failure. I think there's many different mechanisms for this. We're still learning a lot, and hopefully we'll be able to answer some of those questions that you guys may have later on. All right, thanks. Yeah.
Thank you, Dr. Agrawal. That was a great start and just some thoughts to get us started. Up next is going to be Tara Mudd, APRN. Tara is a nurse practitioner with the Norton Heart Vascular Institute Heart Rhythm Center. She also is a leading clinician in our dedicated atrial fibrillation clinic that sees patients with AFib. Tara has been with us for 13 years, and we are excited to hear from her about how COVID is affecting the heart when it comes to heart rhythm issues and kind of what she's seeing in the clinic. Tara?
Thank you, Lauren, and thank you, Dr. Agrawal, for that. So as Dr. Agrawal alluded to, we are currently writing the book on how COVID affects the heart, as well as how COVID affects the heart's electrical wiring. So if you think about your heart, like you think about your house, you've got your plumbing and you've got your electrical wiring. And so we know that the COVID can affect the plumbing standpoint as well as the electrical wiring standpoint of your heart. And initially, when we first saw COVID, we were seeing a lot of issues with patients presenting with palpitations and heart racing, but we were also seeing patients that presented with slow heart rhythms, what we call bradycardia or heart block. And so we were seeing a combination of fast and slow, and we were seeing that those were coming from both the top part of the heart, which is your atria, as well as the bottom part of your heart, which are the ventricles. But as time has gone on, and as I think we've gathered more data and have more of a population to assess, we have found that most of the arrhythmia issues that we're dealing with are primarily from the top part of the heart, or the atria. Not just atrial fibrillation, which is obviously something I see a lot of, but also since arrhythmias that originate from the top part of the heart, such as atrial tachycardia, or what we just call sinus tachycardia, meaning it's a regular rhythm, but it's just a very fast rate. So again, we're primarily seeing more of the atrial arrhythmia, and mostly in patients that are critically ill with COVID-19. There's also the consideration, even if you haven't had COVID, that we may be seeing a lot of these just from the emotional stress of COVID. Even if you may not have it, your loved one may, or you may know someone who has had it or is having problems with it. So there's still a lot of data for us to collect with regards to how much the physiologic and emotional stress that COVID has had on the cause. We know outside of COVID, dealing with atrial arrhythmias a lot of times can be influenced by periods of very high emotional stress. So there's certainly a lot of data that we have to gather with regards to how that's impacting these patients. The important thing to know, though, is when we identify these things and note them either in an outpatient setting or in the hospital, our workup and treatment of them are very similar to those patients who do not have COVID. So there's not any special medications or whatnot that we use for these arrhythmias. We're currently using what our guideline directed therapy is for patients that have these arrhythmias that don't necessarily have COVID. And again, as we study these patients long term, that recommendation may change, but right now our workup process for that is very similar. For patients who we kind of look at patients that have COVID as those that may have had pre-existing arrhythmias and are now having recurrence of that, or those that have COVID that never had any previous arrhythmia issues and then have subsequently developed that. For patients that have had an established arrhythmia problem, we often see recurrences during the acute phase as well as the recovery phase, because again, there's a lot of physiologic stress. There's fever, there's electrolyte disturbances, some of the medications, the antiviral medications that we may use, some of those can cause some recurrent arrhythmias. And then for those patients who did not have pre-existing arrhythmia conditions, again, we see that from those similar types of mechanisms, the stress that the virus has on the body. Another important piece to this from a heart rhythm standpoint is the development of this what we call autonomic dysfunction. And you may have also heard this as referred to something called POTS, or postural orthostatic tachycardia syndrome. And as I mentioned initially, sometimes we're seeing patients that don't necessarily come in with arrhythmias, but that have very fast heart rates. POTS, or autonomic dysfunction, is something that we have seen prior to COVID in patients that may have a viral illness and subsequently develop this for no clear reason. What we're seeing now is because COVID is such a prevalent virus and so many people are getting it, that we're seeing a lot of this, likely from a post-viral standpoint. So it's mimicking what we have seen in the past. It's just that we have so many patients that are contracting COVID and recovering from that virus, that we're seeing an inundation of this type of presentation. There's a lot of reasons why we think that this can cause this autonomic dysfunction. Some of it can have to do with not having enough volume on board. So you can become what we call hypovolemic, and that can be because nausea, vomiting, fever, and then having very prolonged bed rest periods. When you are very deconditioned, that can become part of a very vicious cycle of how this develops. There's also ways in which this particular virus can infect the neurons that are part of your nervous system that help regulate blood flow. And then just this kind of autoimmune response after a viral infection, again, that we have seen in the past prior to COVID, but we have so many patients that are experiencing this. So from an arrhythmia standpoint, that's a lot of what we're seeing are patients that had a pre-existing arrhythmia and it's gotten worse because of COVID, or those that have never had a previous arrhythmia that are now developing it. And again, right now, currently our recommendations for treatment are similar to that of if COVID was not present. So that's kind of in a nutshell what we're experiencing from an arrhythmia standpoint with regards to COVID-19.
Thank you, Tara. There is a question that has come in really specific to AFib, so I just want to take this moment to go ahead and address that while we have you. Sure. Caroline, thank you for submitting your question. I am going to hold some of the personal details that you submitted, but definitely think your question is valid. Caroline's father has had COVID and had AFib detected during his positive experience. She's asking if he is at risk for AFib again, and what should the follow-up be now that he is over COVID, but had COVID, it sounds like had AFib detected during his positive virus.
Sure, that's a great question. And so we tend to, once a patient has atrial fibrillation, we tend to continue to monitor that patient for a period of time to look for recurrence. We know that AFib begets AFib. So once you have the diagnosis, you may down the road be more prone to have that, particularly in periods where you may be sick or ill or contract some type of a virus. So we know that once it happens, there is the likelihood that it may happen again in the future. And so we tend to follow these patients at least for a period of time to monitor them. If a long period of time goes by without any issues or recurrences, then we may be able to transition you to seeing just on an as needed basis, but it's certainly something that warrants kind of follow up to see if the patient does develop recurrence, because again, when your heart's electrical system demonstrates the ability to go into this abnormal rhythm, it's more prone for that to happen again in the future.
Thank you, Tara. That's awesome. All right, up next is Kimberly Vessels, APRN. Kimberly is a nurse practitioner in our Advanced Heart Failure and Recovery Clinic. Kim has been an advanced nurse practitioner for 6 years, solely focused on advanced heart failure. While that sounds really scary, we know for some patients, advanced heart failure sounds like the end stage. For most, they can live a full and happy life while managing and even recovering from their heart failure. So up next to tell us a little bit about what they are seeing in their advanced heart failure clinic, Kim.
Hi, thank you, Lauren. Thank you, Tara and Dr. Agrawal. I'm just going to build a little upon what they've been talking about COVID-19 and your heart. We all know that COVID-19 and during this pandemic, we've talked about myocarditis, we've talked about arrhythmias, and the myocarditis and arrhythmias can lead to heart failure, can lead to a weakening of the heart muscle, along with viral illness can cause a weakening of your heart muscle. When we're looking at patients' hearts, we look at via an echocardiogram or an ultrasound, and sometimes what we'll see is that the pumping chamber of the heart has become weak. A patient's normal heart, we measure using something called an ejection fraction, and can be normal is about 55 to 65% for most of the population. Sometimes we see that to be reduced. Sometimes we see that less than 40%, and we start to get a little concerned about the pumping function of the heart and of that left ventricle of the heart. Sometimes we also see with COVID, with the strain of the lungs, we can see a strain on the right side of the heart as well. And we start to get a little concerned about retaining fluid. Whenever we see this with the COVID-19 or with people with a weak heart muscle, we start talking about symptoms and how long these symptoms have persist. If you feel like that you may have developed heart failure, you may have symptoms of worsening shortness of breath, especially when lying down. You may feel like you're retaining fluid, or may feel like you're drowning whenever you're laying down. You may develop swelling of the abdomen or the lower extremities. You may notice that your pants don't fit right. You may notice that your socks are leaving marks in your lower extremities, or that you can't fit your feet in your shoes. These would all be symptoms of heart failure that you may notice if you are to develop this. Sometimes we have patients that have pre-existing conditions of heart failure, and the COVID is also exacerbating that. So these are just symptoms that you would want to watch for. If you are currently have heart failure and you think that you may be getting worse, or you may be experiencing symptoms of heart failure, we want to make sure that you contact your healthcare provider very urgently. We can help guide your treatment over the phone. What we're seeing in people that have pre-existing conditions is that, or pre-existing heart failure, is that with the nausea, the vomiting, the fevers, sometimes we're seeing that patients don't need as much medication. So their blood pressure may be lower. They may not be tolerating their diuretics or need as many diuretics. So we encourage you that if you have symptoms of heart failure, or if you have heart failure already, that you contact your healthcare provider so that we can help you guide your medical therapy. One of the things that Lauren did mention was our advanced heart failure and recovery. So she mentioned that we can live a long life with heart failure. Something specific of our program is that when we find patients that do have a weak heart muscle, we develop a treatment plan for you that involves aggressive medication titration that can help with recovery of your heart function. So just because you developed heart failure with COVID, or around the time of COVID, or had it in the future, does not mean that we can't make your heart stronger again. And I think this is very important to understand, that we can see recovery of the heart muscle once we see this. Oftentimes, we also have patients that instead of having a weak heart muscle, you have a stiff heart muscle. And when the patient's heart muscle is stiff, you may hear something called heart failure with preserved ejection fraction. So these patients have a normal ejection fraction, but still retain fluid. This is because the heart muscle doesn't relax well. And especially when there's stress from the lungs, this can cause your heart failure with preserved ejection fraction to be worse. Again, we encourage you to call us so that we can help with your management of your diuretics and treat your symptoms. Just because you have heart failure and COVID doesn't mean that we can't see you. We will be happy to see you over telehealth to help guide you through your treatment. We know a lot of patients want to stay home. We encourage you to stay home if you can. Of course, we want to see you in the hospital if we feel like you need to be in the hospital, but we can help see you daily to help with your management while you're at home. And again, if you feel like you have an acute illness, we want you to contact your healthcare provider so that we can help treat you for that. One of the other things that we see is hypertension. When these patients get with COVID, you can get hypertension. And this can also cause your heart muscle to be weak. We want to keep that controlled. So again, give us a call so we can help treat you. What else can we mention, Lauren? Do you have any other thoughts?
There are a few general questions that are coming in. As a reminder, if you have any questions, the panelists are ready and prepped to give you the best answers that we have on hand. And if we don't have an answer we can offer you today, we can always follow up with you later if needed. So be sure to put your questions down in the Q&A, but there are a few ones that have been coming in. Lynn says, what about those who already have heart issues and are recovering from COVID? Should I be following up with my doctor, my cardiologist, because I already saw them to begin with? So whoever, I don't know if that's Dr. Agrawal or Kim.
Yeah. Yes, we do encourage you after recovering from COVID to contact your healthcare physician so that we can see you in the office. If you're still having symptoms, if you're one of these COVID long haulers, we want to make sure that you've had no weakening of your heart muscle through this illness. So we may order an echocardiogram or a cardiac MRI to look at your heart function a little bit further.
Thanks, that's great. This one is for Dr. Agrawal, a question about if I feel like I'm noticing symptoms, but they don't seem major, what does the workup look like or where should I start?
Yeah, I think as both Kim and Tara mentioned, with COVID, it can cause exacerbation of underlying issues, but can also cause new issues. So depending on the symptoms, a general workup will include an EKG, possibly an echocardiogram, sometimes a stress test if people are having persistent symptoms, and occasionally a cardiac MRI to rule out myocarditis. A lot of it depends on the type of symptoms and the severity of symptoms and when they're occurring. So it's common to have a little bit of shortness of breath, some palpitations early on after COVID. We start to get worried when these symptoms persist, and especially when they're causing issues with your quality of life. So it's important to contact your healthcare provider regarding any problems because, as we've mentioned, the presentation can be very variable and can depend on many different issues.
Awesome. Thank you, Dr. Agrawal. Here's one from Kathy. Thank you, Kathy, for submitting this. Kathy has a question about a structural heart defect like bicuspid aortic valve or mitral valve regurgitation or in prolapse. What are you seeing in relation to structural heart defects as it's related to COVID, or are we seeing any differences related to those versus other types of heart conditions?
Yeah, I think in general, those patients who have valvular heart disease are not having any progression or change in their valvular heart disease. Some valvular heart disease can be flow dependent or dependent on your volume. So if you're very sick in the hospital, sometimes those can be exacerbated. But if people are having have valvular heart disease and are not hospitalized with their COVID-19, in general, there is not an exacerbation of those structural changes.
Okay. Another one from Sandra. How would pre-existing pulmonary hypertension affect the cardiac outcomes as it relates to COVID-19? So this one is in regards to pulmonary hypertension.
I think I can answer that. So depending on the reason for your pulmonary hypertension, which can be for various different reasons, in general, a COVID-19, the outcomes are worse with patients who have pulmonary hypertension, meaning increased hospitalizations, increasing death if they do get COVID-19. The best way of reducing that risk is going to be for vaccination. So making sure that you're vaccinated will help reduce that risk. In patients that are hospitalized, there can be worsening of the pulmonary hypertension. Again, as I said, this is also can be flow dependent or load dependent. So those who have a lot of fluid on board, who develop worsening lung issues, their pulmonary hypertension can worsen with this. So it is important to follow up with either your cardiologist or your pulmonologist to reassess that and to monitor clinical symptoms to make sure they're not getting worse.
Thank you. This is a good one that's probably to Kim and Dr. Agrawal, but Tara, if you have anything, I know heart rhythm definitely applies to this as well. Lisa says, I'm hearing of young adults getting COVID, minimal symptoms, and then having heart issues following their COVID-19 infection, even athletes. What are you all seeing as it relates to young adults and COVID?
So go ahead, Tara.
Well, it's strange because we certainly have seen cases of, from an arrhythmia standpoint, where young persons, that really don't have an established cardiovascular disease that present with arrhythmia issues afterwards. And again, kind of when that occurs, we really start to kind of dig down into, could there be a cause that maybe we just haven't identified yet? Because your body is put under so much physiologic stress from having COVID. Sometimes it reveals things that you may not have otherwise seen. And so, the treatment of arrhythmias, particularly atrial fibrillation, is a very complex thing. It's not simply, here, take this pill, it will fix this, but rather a comprehensive look at risk factors. There's a lot of things that can influence development of atrial fibrillation, and not just age. It can be, family history. It can be caffeine intake, alcohol intake, smoking, sleep apnea, diabetes, thyroid disease, a lot of these things that may not have been identified before that could be potentially a trigger for this. And then the onset of the viral illness can kind of compound that and make that presentation much earlier on than we would have seen. So from an arrhythmia standpoint, we certainly are seeing that. But again, the treatment and kind of working that patient up mimics that of what we would see for someone that did not have COVID. We would still go through those risk factors, try to determine what may be a potential trigger. Sometimes there are situations where we simply can't find a clear identifiable cause, and they've had this, and could we say, yes, this is the result of the viral illness? But we would also have that same response if a patient didn't have COVID, but let's say maybe had the flu and developed atrial fibrillation as a result of that. So we would still basically say this likely could be from a post-viral cause, but we're going to treat it just like we would any other patient.
Yeah, I think it's important to note that the post-COVID syndrome, the long hauler COVID, can occur regardless of the severity of the initial infection. Additionally, with myocarditis, there's been a lot of information out there, and there's been a lot of questions about what we should do, in particular with athletes. The Big Ten actually did cardiac MRIs on all of their patients who came, or all their athletes who had COVID. And they found that about 3% of the athletes developed myocarditis, a subclinical myocarditis, meaning that there was some evidence of inflammation of the heart muscle, and regardless of the severity of the infection. About 0.5% overall developed symptoms, which include chest pain and shortness of breath. So if you're an athlete and you get COVID-19, it is important to discuss with your doctor and maybe see a cardiologist regarding the risk, because it does warrant workup, including sometimes an ultrasound, sometimes an EKG, just depending on the symptoms that you're feeling and other factors.
Okay, here's one that's really specific to AFib for Tara. And Tara, I'd ask that you describe what some of these things mean. Kelsey says, when managing AFib patients who are already on an anticoagulation for VTE prophylaxis before contracting COVID, can you speak to the complications that you're seeing as it relates to the management of VTE risk?
So if someone has a pre-existing issue, VTE is a thromboembolism, so basically a blood clot of some other kind. It could be in the lung, it could be in the leg, but having some type of a clotting issue and already being on a blood thinner for that. So when someone then develops atrial fibrillation, you have to look at, typically with VTE, the anticoagulation dose is, after the initial acute period, is going to be the same and sometimes even less than what we would prescribe for someone that has atrial fibrillation. So if the patient was on anticoagulation for a previous issue and is on a dose less than what we would recommend for AFib, the AFib then trumps that. And so we would increase the dose of that to treat their AFib. Now, if their stroke risk from atrial fibrillation is significantly low, then we may defer back to those original VT indications. So to kind of summarize this a little bit more simply, when someone has atrial fibrillation, we determine their risk of stroke based on something called the CHA2DS2-VASc score. And it's a score anywhere from 0 to 9 that takes into account a patient's age, sex, and medical history and assigns them a score. 9 is the highest risk and 0 is the lowest risk. Our guidelines tell us that anyone that has a score of 2 or higher should be on an anticoagulation. If their score is a 1, the guidelines suggest that either anticoagulation or aspirin would be acceptable, and a score of 0 is you don't have to have them on anticoagulation. So if a patient develops atrial fibrillation and their score, which we would calculate in the office, is a 2 or more, then that warrants them remaining on anticoagulation at the dose appropriate for their atrial fibrillation. So I hope that answers the question effectively.
I think it does, Tara. I think it just further emphasizes just what a delicate balance all of this is and how every patient is so different. And then introduce a virus like COVID-19 that can kind of send things out of whack for a short period of time, or even a longer period of time, and how important it is to just touch base with someone like you who can adjust and tweak and make those changes as you recover from COVID. So I think that definitely highlights that. As you went through that, I was like, oh my gosh, I don't know how we would ever keep up with that. So I'm so grateful for people like like you and the other panelists. There is a blanket question in relation to clotting around the same aspect. So either I would say Agrawal or Mudd. Do you recommend baby aspirin for people recovering from COVID due to a higher risk of clotting? This sounds like for someone who was not already on an anticoagulation. Are we making that blanket kind of recommendation?
I can take this. I think there's a lot of, it's unclear. There's no blanket recommendation at this point. They've evaluated this and the data is very variable. In general, if people are at low risk, we're not recommending aspirin. But I think since there's a lot of nuance to this, I think I would discuss with your doctor. A lot of it depends on your mobility, some of the lab factors if you are sick enough to be in the hospital. But there's no clear answer, and I think it's worth a discussion with your doctor. I personally have not been generally recommending it to most of my patients, especially outpatients.
Anyone else have thoughts on that they want to add?
I would agree with that. It's not a blanket recommendation, but something to kind of be discussed personally with your particular risk.
Awesome. Kim, I know that you shared some signs and symptoms that people should look for as it relates to heart failure, but a question has come in about, I've had COVID and I did not have heart issues before. What are some signs and symptoms that I may not be aware of that I need to be mindful of as it relates to my heart, or maybe a new onset heart? So if we want to start with Dr. Agrawal from a general cardiology, and then Tara, if you could share some initial signs and symptoms of AFib or other heart rhythm issues that may be present.
So from a heart rhythms standpoint, people can feel like their heart's beating irregularly. Your heart is usually on a very regular rhythm, but sometimes people will feel just either what feels like a skipped beat or an extra beat. And sometimes that can happen rarely, sometimes that can happen frequently, and depending on the frequency and the symptoms associated with it will depend on what the next steps are. Other symptoms can include shortness of breath, chest pain, fatigue, and low energy. Can all be symptoms of an arrhythmia or other cardiac issues that come with this.
Tara, anything from a heart rhythm perspective that people should be mindful of?
It's similar to kind of what Dr. Agrawal alluded to. So the sensation of an irregular heartbeat or heart fluttering, racing. Sometimes people feel like their heart's beating in their throat, or they feel like a bird is fluttering in their chest. So that experience can be very different for other patients. It can manifest as chest discomfort. It can manifest as simply shortness of breath. It can be fatigue, which is obviously very complicated considering one of the main side effects after having COVID is very fatigued and tired. And so you may not necessarily be able to identify, is this fatigue from a heart problem? Is this fatigue just from COVID? And so that's, kind of part of why discussing this with your primary provider and then kind of digging down a little bit deeper just based upon some of the other symptoms. But just important to not, as Dr. Agrawal alluded to in the initial portion of this, is not to just brush it off as COVID. It may be related to something else. But most commonly, I would say from an arrhythmia standpoint, palpitations, heart fluttering, skipping, racing, things like that.
Thanks, that's great. John puts in a funny comment, and I will read it for the group because I always love these connections. But he asks, beyond the usual CDC recommendations regarding COVID prevention, are there any other steps that heart patients in particular should take? And then he also adds in, and hello, Dr. Agrawal, any news since 7th grade? So this must be an old classmate of Dr. Agrawal. John, we're so glad to have you on today. But any other recommendations from the panel as it relates to heart patients and prevention of COVID?
So not much has changed in 7th grade. My humor is about the same. Voice is a little deeper. But regarding the beyond what the usual CDC recommendations are, there aren't any specific steps I would recommend. I think vaccination is very key. We know that the rates of hospitalization and the rates of death are significantly lower in patients who are vaccinated, almost 20-fold lower. And those findings are amplified in those who have pre-existing heart issues. Making sure that you're vaccinated, making sure you're masking in public places, avoiding big crowds is important. Additionally, there is some data that people who have uncontrolled hypertension have worse outcomes with COVID. So making sure that you're monitoring your blood pressure closely, making sure your diabetes is well controlled, making sure all your cardiac risk factors are well controlled are important. And then the usual CDC recommendations, I think, on top of that. We're not.
Oh, sorry.
Sorry, I'm sorry. At the beginning of the pandemic, there was some discussion about whether certain blood pressure medications should be started or stopped. We have not seen that people should. There is no good evidence that you should stop or change your blood pressure medications if you do have COVID. And then there is a little bit of evidence about statins or cholesterol-lowering medications actually being beneficial for those with COVID. So making sure that you stay on your medications.
I'll throw a follow-up question to Kimberly. Kimberly, Dr. Agrawal touched on the importance of hypertension and just management of that and keeping it down. How does that relate to patients that you're seeing in the heart failure clinic as it relates to unchecked hypertension, or if we're seeing an early onset for heart failure?
We're seeing early onset in some populations, young African-American men, especially with uncontrolled hypertension that may contract COVID, are more at risk for developing heart failure. That population is very high for us, a population that really needs to be controlled and needs to be watched very closely. I would continue to encourage diet and exercise and making sure that we're eating well and exercising to help control that hypertension and help just keeping us overall in better health. We do see worse outcomes in obese patients than we are other subsets of patients. So I think that that's very important to monitor. And of course, goes along with just preventative medicine in managing hypertension, hyperlipidemia that Dr. Agrawal was talking of.
That's great. This is for the whole panel in relation. Obviously, we've heard Dr. Agrawal support a vaccination for someone who has heart disease as a way to have preventative to COVID-19. Jeannie follows up with a question that says, how many people have you seen that have had myocarditis as a result of getting the vaccine? And Dr. Agrawal, you may not have that data in front of you, but just if you have any anecdotal thoughts about that.
Yeah, so COVID-19 after the vaccination, myocarditis after the vaccination is something that has been seen. It's an extremely rare event, and the occurrence is probably on the order of 1 to 10,000 in the highest risk population. So you may have heard that patients who are essentially young males are the ones that are getting this most frequently. But even in the highest risk population, the risk of myocarditis from the vaccine is significantly lower than getting myocarditis from COVID-19. So it's almost a 10 to 20-fold increased risk from getting it from getting myocarditis from the virus versus the vaccine. In older individuals, the risk of myocarditis does not seem to be higher post-vaccination. In females, the risk may be slightly higher, even in young females, but the risk is not, the main risk cohort is young males. And even in that cohort, the risk of myocarditis from the virus is significantly higher.
I would echo what Dr. Agrawal said. I anecdotally in my office, I have seen 0 patients that have developed myocarditis as a result of the vaccine. And so just to echo, what Dr. Agrawal said, the incidence of developing that significantly higher from having a severe COVID infection without being vaccinated than those who have been vaccinated as a result of that. So essentially exactly what Dr. Agrawal said.
I think it's also important to note that even the people that are getting myocarditis generally are having a self-limited disease. Their symptoms are managed with medications, and the long-term effects are something that we need to figure out and still need to learn. But I think most of these patients are discharged from the hospital if they're even hospitalized at all.
I would mimic that same. We have not seen anyone, and all the research that I have seen has shown, 0 mortality from myocarditis from the vaccine. Everyone is recovering, but we haven't seen anyone.
That's great to hear. Any final closing thoughts from the panelists, and then we will wrap up with some additional information. This gives a couple more minutes if you have any other follow-up questions, but any final thoughts from our panelists here today?
I would just encourage everyone, if you have not been vaccinated and you just have questions or you're scared or you're not sure, please talk to your provider. We would be happy to sit and talk with you. I think I speak for all 3 of these panelists today that say that getting the vaccine significantly decreases your risk of severe cardiac complications from COVID. And so if you haven't had the opportunity to do that yet, please reach out, talk to your provider so that we can help guide you through an informed decision so that you can make the best decision for you, but also to, again, help prevent some of these cardiovascular complications that we are seeing as a result of the virus.
Thank you, Tara. I will share some final opportunities to connect with the team as needed. Hopefully you all can see the screen on the side. If you feel like you need to connect with one of our specialists and aren't sure where to start, a great start would be the just a second, Norton Heart Vascular Institute.com. As I mentioned earlier, we have a team of more than 60 subspecialty providers that are able to cover the comprehensive span from general cardiology all the way to heart surgery. If you feel like you need to connect with a heart or vascular subspecialist, feel free to visit Norton Heart Vascular Institute.com, or you can call our Access Center at 502-629-1234. In addition, if you have had a positive COVID result and you continue to have follow-up symptoms, we recommend that you follow up with your primary care. If you have a previous diagnosis, you can always follow up with your subspecialist who's provided care for that. Or we also have the Norton Infectious Diseases Institute long-term COVID care clinic. This clinic is for patients who have had a positive COVID test result, and they are usually 8 to 12 weeks post-recovery, but still having symptoms or still having complications and need to speak to somebody about their recovery journey. The telephone number is listed there below, but you can reach them at 502-861-4488. That is a self-referral clinic, but they will confirm kind of your journey and the positive COVID test results. So please reach out if you need that assistance. As always, the Norton Healthcare team is here to assist in any way possible. Thank you so much for joining us today. We will continue sharing information as it comes out as best as possible. And we wish everyone on this call health, wellness, and stay safe. Hug those you love and come back to see us next time. Hope you guys have a great day.